To our webinar for this week. We are going to be talking today about the assessment of psychosis risk syndrome in the real world. And we're very excited to have two presenters with us today, Barbara Walsh and Jennifer Newfield, and we're going to have them introduce themselves in just a second. As ever, these are one of our monthly series of clinical high-risk webinars where we're addressing different topics each month. And as you can see there in the public chat box, Tamara Sale has outlined some of our upcoming webinars that we will talk more about in a little bit. And Tamara is going to tell you a little bit about the evaluations and things before we dive into the webinar for today. So Tamara, can you tell us about that, please?
Yes, there is going to be one. So there will be a link at the end. And it's very important to us that you actually provide feedback. So I'll remind you again at the end, but back to Kate.
Thank you. All right, so I'm not sure, am I supposed to be in there? So I'm going to advance slides. Here we go. So we are hosted here by the National TA Network for Children's Behavioral Health through the University of Maryland, and as ever, very grateful for their support to run this series of webinars for clinical high risk for psychosis. And today we're going to be talking about the assessment of clinical high risk within the real world setting. And I'm just going to pause and ask Barbara first and then Jennifer to introduce themselves. So Barbara, would you mind just giving a brief introduction?
Sure, Kate. Thank you. I'm Barbara Walsh. I am the clinical coordinator of the Prime Clinic at Yale University School of Medicine. I am one of the co-authors of the SIPS assessment, and I travel really all over the world training people on its use.
Thank you, Barbara. And Jennifer?
Sure. Hi, I'm Jennifer Newfield, and I'm a licensed clinical social worker. I've been working with the First Hope program in Contra Costa County in California for the last 6.5 years. I helped start the program. I've been working in mental health for over 20 years, and I've been using the SIPS assessment for the last 6.5 years, and I'm very excited to be here.
Great. Well, thank you to you both for joining, and I'm so excited that you're able to come and share your expertise and to have two individuals who know so much about this topic to be able to share with the group today. So as we're going through, the participants, please feel free to be adding questions to the chat box. We'll either answer there and then, or we might return to those questions later on towards the end. And I'm just going to hand over to Barbara now to get this started. Thank you.
Okay, thank you very much, Kate, and welcome everybody. We're really thrilled to see all of the enthusiasm for this topic. It especially means a lot to me to see so many more people doing this work, so thank you. I'm really going to start off with some basics of prevention this morning. I think it's very important when people think about early intervention work that they really frame it. This is about prevention. This is not about labeling someone or judging someone. It is about recognizing that psychological and emotional difficulties are just like any other medical problem. Early signs and symptoms present before the illness develops. And just like with other medical illnesses, the sooner we recognize those problems, the sooner we can treat them, the less likely they are to have a negative impact on people's lives. Excuse me. So the analogy I always like to give is, if you had a mom who had a heart attack at 48 and a grandfather who had a heart attack at 50, and you have some high blood pressure and high cholesterol, your primary care physician is going to refer you to a cardiologist. Why? Not to diagnose you with heart disease necessarily, but to develop a prevention plan so that you can avoid developing heart disease or at the very least mitigate it if it is to develop. And a lot of times people will say to me, well, why does someone need a specialty care program for being at risk of psychosis? And my answer would be, why would we treat mental illness less than we would any other physical disorder? We are referring people to a specialty clinic to get assessed for risk of developing a psychotic disorder for the very same reasons, to either help prevent the development of psychosis or at the very least to mitigate it should it develop. And again, stressing it is to establish risk versus a diagnosis. We want to develop a formulation of the individual's problems. And again, I want to stress, when you're doing early identification work, it is not whether the person has the symptom or not that becomes crucial. It's what they make of the fact that they have the symptom. And that's why it is based on their individual perspective. It's why we are evaluating internal experiences, and no one else can report on that except the patient themselves and what we observe. And that's why we don't diagnose risk based on collateral information. We, of course, want to rule out a past or current psychosis, recognizing that a person cannot be pre-psychotic if they've ever been fully psychotic. Even if they're no longer actively psychotic, that would be residual psychosis, but it wouldn't revert back to pre-psychosis. And we want to be very careful. One of the things, as I travel across the world doing this work, one of the things that we don't all agree on just yet is what defines an early psychotic episode, a first psychotic episode. Some of the clinics I visit identify it as the past 3 months. Some places identify it as the past year. Some people identify you had to have become psychotic in the past 3 years. So it's very important that we're able to date the onset of a patient's first psychotic episode. Number one, so that we're not overdiagnosing first psychotic episodes, but number two, that we're being true to whatever our definition of first psychosis is. And then we want to rule in the history of psychosis risk syndromes. There are 3 of them, and certainly in research settings, all 3 are important. But out in the real world, the one that is most important is the attenuated positive symptom syndrome. That is the one that is described in the DSM-5, and that is the one that is used in clinical practice. And we want to rate the current severity of the psychosis risk symptoms so that we can plan their care and treatment, taking in all the aspects of the disorder. Very important that you recognize CHR is a stress vulnerability disorder, and so as the young person's stress level goes up, as they experience transitions or stressful events like exams and big reports being due in school, and even significant social events like formal dances or proms, this all tends to exacerbate their stress level and makes them vulnerable for an increase in their symptoms. Being aware of that helps us prepare our patients so that they can anticipate that increase in symptoms so they don't get blindsided by that occurring. One of the things that's very, very important, I just want to remind people the SIPS, this assessment, is not meant to be used on a healthy population. It is about them being help-seeking. Help-seeking either because they themselves are distressed by their symptoms or others are noticing a change in their functioning due to these symptoms, and it's starting to interfere with their life. So it doesn't have to be both. It can be either or. And if you read the literature, it really does stress you have to assess the entire spectrum of the patient's well-being. So certainly that looks at their sleep disturbance, their anxiety, their mood disorders, their concentration issues, their life circumstances. What is their trauma history like? Have they been going through a number of transitions that may be increasing their stress? And you want to look at all the things that impact their general health and well-being. Again, their nutrition, their hydration, whether they're moving and getting any exercise, what are their stress management skills, and certainly their ability to be social, and how is that impacting them. It's very, very important that you utilize some type of a pre-screen before you conduct the formal assessment. It doesn't matter which you choose. There are many available out there. Some people devise their own individual phone screen. The Prime Clinic does have a 12-question questionnaire that is available to anybody. In fact, we leave it in guidance counselor's office, pediatrician's offices, so that if they have people come in who are expressing some mental health concerns, it's pretty quick to just do the 12-question questionnaire, and then they know whether it's appropriate to make a referral to a specialty clinic like ours. Rachel Lowy's PQB is also available. You can make up your own screening method. The important message is that you do pre-screen and at least establish the basic eligibility criteria, which is that someone must be between the ages of 10 and 45 for the SIPS to be valid, and they must have a minimum IQ of 70. When you utilize the SIPS, you have to read the questions exactly as they're written, and the verbiage needed for that, you would have to have a minimum IQ of 70 for it to be a valid assessment. And I just want to remind people, the pre-screen does not determine the risk for CHR. It just determines whether the structured interview should be completed. I'm not suggesting that anyone can diagnose over the phone. All I'm suggesting is that you can immediately rule out if there's anything that makes someone ineligible for the SIPS. And, which you certainly want to do because you want to establish basic eligibility issues, and you want to avoid any unnecessary evaluations, which is, difficult on the patients, and it's also a resource issues for our clinics. And again, I just want to reiterate, it's not just about whether a person has a symptom that would be considered CHR. It's what they make of the fact that they have that symptom. Is it significant to them in some way because it is at least captivating, perhaps distressing, or interfering with their day-to-day functioning. It is the SIPS, the structured interview for psychosis risk syndromes. You can read all about the predictive validity, the construct validity, the sensitivity, the inter-rater reliability in the American Journal of Psychiatry. May of 2002. But what is important for you to know is that it is a semi-structured interview. So you are following a certain format. All of the questions need to be read exactly as they're written, in the order that they're written. All of that contributes to the validity of the assessment. And how you introduce the assessment is the very, very first step in this process. It's very important that you let the young person know that there truly are no right or wrong answers, because we all have different experiences. And we're not here to label them or judge them. We are there to just help understand their experience and make recommendations for things that perhaps would make them feel better. And you will see when you introduce it in that way, it immediately reduces the young person's stress level, which gives you a more valid assessment. You want to be very careful that you conduct the assessment in the appropriate manner within the appropriate time limits. Unfortunately, sometimes when people are new to the SIPs, it takes them longer. And, you know, we don't want to see SIPs taking 2.5 hours, because then you're stressing your patient and your results will not be as valid as possible. Typically, a SIPs takes an hour to an hour and a half at most. It does diagnose the 3 different prodromal states, and it also diagnoses the presence of psychosis if it is there. It is translated and validated into 15 different languages. It is being used in all those languages around the world, across all cultures. And what is very exciting about that is the reliability and the validity holds true for the assessment across all cultures if people are following the guidelines and utilizing a culturally sensitive interview format. It is valid for persons 10 to 45. They must have that IQ of 70. Outside of that age range, or an IQ less than 70 would make the SIPs invalid. Now, some other things are going to impact how valid the SIPs is. Certainly, if the patient has greater than 5 concussions, and we see this often with young athletes, so in the overview section, you would certainly query about that. And what you might want to do in that case is have them evaluated by a neurologist to get a rule out for it being better accounted for by some type of neurological disorder, which is certainly true with certain seizure disorders or traumatic brain injuries. The other thing that might invalidate the SIPs, if the SIPs was not available in the person's preferred language. So as I mentioned, so far it has been translated and validated in 15 different languages. And if you need the SIPs in any other language, please do just email me and I'll be happy to get you a copy of it. It is valid for use with an interpreter if need be. The other thing that would invalidate a SIPs, which I failed to put on this slide, is you cannot conduct the SIPs with an electronic device. So you can't use it on a laptop, on a tablet, even on a phone. It needs to be done pen and paper, because any kind of electronic device increases this patient population's suspiciousness and will skew the results. On the SIPs, there is an option of rating yes, no, or no information for each of the items. And again, there are times when it is legitimate to rate NI. The only thing I would say, if you have too many NI ratings on the positive symptoms, then I would question the validity of it at that point. And certainly if a person is too actively psychotic or disorganized to effectively report their symptoms. So as I mentioned, in the real world, the syndrome you're going to be concerned with is the attenuated positive symptom syndrome. And that is that sub-threshold of psychotic-like symptoms, but the patient maintains insight that they are not real. But despite that fact, the symptoms are either interfering or distressing to the person. And it is a risk syndrome for a psychotic form of illness. But it is very important that you understand the SIPS does not differentiate between schizophrenia spectrum psychosis and affective spectrum psychosis. It just alerts you to the fact that they are at higher risk than the general population for developing a psychotic disorder. The statistics hold pretty steady at about a 20% increase of developing a psychotic disorder. Their symptoms are more transient than full-blown psychotic symptoms, and as I said, their insight is maintained. One of the things I'm very happy to very briefly talk about is the SIPS was originally authored for research protocols, and now we have moved forward after 2 decades, and we are ready to really use this effectively in clinical settings. So there will be a new version available for clinical practice that is much shorter, more 15 to 30 minutes, that will be available in the near future. It is the most commonly used structured interview for diagnosing clinical high risk, CHR. It maps on to the DSM-5 diagnosis 298-9 or the ICD-10-F28 diagnosis. It is designed to be an interview assessment, and again, that was based on the research that there is more validity in trained interviews as opposed to self-reports of these types of symptoms. And a lot of people ask me what is needed for a person to be a good SIPS assessor. First of all, I do think you need some skills in how to conduct a good psychiatric assessment. You need some familiarity with the stages of psychosis in general. So some general clinical experience with the population, but you also definitively need specific training. Dr. McGlashan, who is the first author on the SIPS, did copyright it, not because he would ever charge anybody for the assessment, but just because he wanted to ensure that people are appropriately trained, okay? People need that certification so that they are utilizing this to help young people, not to assess risk in any way, shape, or form. So again, you need basic skills, but then specific training. And there is a website called thesipstraining.com where you can read more about what is required. Some of the general assessment skills that are needed for efficacy certainly is a culturally sensitive interview. You have to possess a high level of sensitivity to the existing symptoms, but also to the normal developmental stages of young people, remembering that the highest risk for this development of CHR, or clinical high risk, is that 12 to 25 group, where, let's be honest, it's linked to the process of puberty. A lot's going on in that stage, so you do need to have some awareness of that as well, and to the gradual change in their psychosocial functioning that happens in that age range, and an understanding of the array of the presentations that psychotic disorders can take. So some understanding of the difference of what major depressive disorder with psychotic features looks like compared to, say, schizophrenia or even PTSD with psychotic features, and also the natural history of a psychotic episode. So if you're familiar with the DSM-5 criteria, you'll know that the symptoms have to be present for a diagnosis of schizophrenia for 6 months consistently. But that does include the prodromal, the active, and the recovery phases of the disorder. And so it's very important that you recognize those transition points from the prodromal or pre-psychotic phase to the active phase and then the residual phase, and how treatment differs in those different stages. And again, just some proficiency in performing psychiatric assessment and the ability to make the differential diagnosis, because we are very, very clear that people have comorbid diagnoses, but that comorbid diagnoses can't better account for what we're seeing as the APS or CHR symptom. In fact, 73% of patients who meet CHR criteria do indeed carry another comorbid diagnosis. In 41% of the cases, it's a depressive disorder diagnosis. In 15% of the cases, it is an anxiety disorder diagnosis. And there is certainly comorbidity of substance use. Very frequently, when these young people develop symptoms, they begin to self-medicate with either marijuana or alcohol, and they, utilize that thinking it's helping them, but it actually can, in fact, make their symptoms worse. And it's also sometimes very difficult for people to distinguish what the negative symptoms of schizophrenia, how they differ from the depressive symptoms and what makes a different diagnosis. So just so people are aware, there are 5 positive symptoms on the SIPS, and they are unusual thought content, suspiciousness, perceptual abnormalities, grandiosity, and disorganized communication. They are the 5 symptoms that people make a diagnosis on. The frequency of their endorsed by patients who meet CHR criteria, unusual thought content is the most frequently endorsed. Suspiciousness is second. Perceptual abnormalities is third. Disorganized communication is fourth. And grandiosity is the least frequently endorsed symptom. So that is how they present. It is also how they link to conversion to psychosis, okay? So if a young person scores high on unusual thought content or suspiciousness, they are more likely to convert to psychosis. Those two are most closely linked to conversion. We do know that people can convert up to 10 years out from being diagnosed as meeting the CHR risk criteria, but the most difficult or the most significant, most vulnerable time is the first 2 years from the onset of CHR. So if you're thinking about implementing a treatment program, you want to take that into consideration because you want to make sure you cover those first 2 years. In order to make the diagnosis, a patient needs to meet in the APS range, the attenuated positive symptom, prodromal symptom range, at least one positive symptom. But more importantly, there has to be an onset or worsening in the past year. The statistics on conversion to psychosis drop drastically if people are not honoring the onset or the worsening in the past year. If you conceptualize that the prodrome is fluid or moving, unraveling, so to speak, kind of picture water circling a drain, okay? That's, if it's long-standing and stable, it's the exact opposite of CHR. So you do need to capture that onset or worsening in the past year. And as I mentioned earlier, it either has to be distressing to the patient themselves or interfering in their daily functioning so that it has become obvious to other people in their life and not be better accounted for by another Axis I disorder. The reliability of the SIPS diagnosis is in the excellent range. There have been 16 studies across the world in diagnostic agreement in CHR, and they all have come out in the excellent range. And it goes even higher than the 0.89 when it is based on the P1 and the P2 scores. Again, being connected to the information that those are most closely linked to conversion to psychosis. It also is important to understand some of the epidemiology studies that are going on for clinical high risk. There have been 11 published studies so far to date, mostly in Europe, Asia, Israel, and the U.S., and they distinguish between a clinical sample and subjects referred or recruited for evaluation, okay? And very, very important to stress this to people. In the general population, it is estimated that about 3% of the general population will meet for CHR criteria. However, in clinical settings, 20.3% of the population showing for treatment, coming for treatment because they are experiencing difficulty, meet for CHR. It is much more prevalent in help-seeking populations. And that is why the research is showing that the awareness of the CHR diagnosis and its clinical implications needs to be increased in clinical settings so these young people aren't falling through the cracks. And again, you know, I want to stress they can also carry comorbid diagnoses, but if that comorbid diagnoses, if the symptoms that you're seeing as CHR are most characteristic of that other disorder, then you better account for it by the other disorder as opposed to when it comorbidly exists. So, for example, I always use the story of a young woman who reported to me that she was very suspicious of other people. If she was walking down the street and someone was walking towards her, she wouldn't trust them and would cross the street. And as we talked more, it came out that she had been the victim of rape. So it was then my requirement to determine whether the suspiciousness was better accounted for by the rape or whether it existed in a concurrence with the rape. And in her case, the two trials that you give it are temporal sequencing. Did the symptom pre-exist the trauma? In her case, it did not, so therefore it couldn't be better accounted for. Or in other cases, it could be, is it more indicative of the characteristics of that other disorder? So, for example, in the case of major depressive disorder with psychotic features, if someone perhaps on P4 reported that they heard a voice only when they were depressed and it was always very, very negative, telling them they were useless and worthless, that would be better accounted for by major depressive disorder with psychotic features, as opposed to being primarily an indicator that they were at risk for psychosis. What are the benefits of early identification? Certainly to prevent, delay, or reduce the impact of psychosis, but more importantly to the patient's everyday life, to reduce their psychosocial disability. If they are going to go on to develop psychosis, we know it is important to reduce the duration of untreated psychosis, to keep that as short as possible. We also know that there are many bizarre behaviors that can occur to someone as they develop psychosis, and we would like to reduce the likelihood of those behaviors or incidents that might stigmatize or traumatize a person. And also research has shown that it reduces the need for inpatient care, which is always better. If we can treat our patients outpatient, it is also less stigmatizing and traumatizing for them as well. Some of the other potential benefits is their ability to engage prior to psychosis. So before that real suspiciousness comes in and they don't trust us as their treaters, when they are still in the CHR phase, they usually recognize that something is different and changing, and they are very concerned about it. They want help. Because they want help, they are much more likely to be an active participant in their treatment plan, and if they are, their treatment plan has a much better chance of being effective. The other thing is it gives us the opportunity to develop a therapeutic relationship with the young person before their symptoms exacerbate. It allows them to have rapid access to treatment, again, helping to reduce the DUP. It also helps us develop new strategies for improving the prognosis of at-risk people, and it certainly has been demonstrated to have cost effectiveness as well. The American Psychological Association has released its policies regarding the treatment of clinical high risk. It does support continuing research, but it encourages clinical treatment, stating there is a positive benefit to risk ratio, and clinical strategy should include frequent being under 30 days based on the original Australian research in this area of interviewer-assessed assessments like the SIPs with psychoeducation and support over the course of the prodrome to its resolution, regardless of whether that resolution is to remission or to the treatment of psychosis. And again, I just want to remind people that the purpose is to reduce the symptoms and disability associated with this syndrome, to improve the social and occupational and educational functioning. There are very, very easy, quick interventions that we do with the schools on a daily basis that help this CHR population be more successful in school. They don't cost anybody any money, but they are truly, truly effective in helping this population to be more successful. And we can reduce the duration of untreated psychosis. All very, very good things for our patients. In conclusion, I guess what I would want to say is at-risk research in psychosis provides a rationale for service provision for those in need of help. Again, remembering we're not doing this on a healthy population. We are doing this on people who are having experiences that are causing them distress or interference. So they are presenting for help, and then we are assessing to see if this could help explain the experiences that they're having, and we can then change the trajectory for those who have a vulnerability for this psychotic disorder. So I thank everyone, and I see I have some questions. I'm not sure, Kate, if you want me to take them now or save them till the end.
I think if it's okay with you, we'll save them until the end. Let's hear from Jennifer, and then we'll know what our timing looks like towards the end. But we are collating all of the questions, sorting through them, and we'll come back to them after we've heard from Jennifer.
Okay,
Thank
great.
you so much, Barbara.
Okay.
And over to you, Jennifer. Thank you.
Okay, thanks, Kate. Can everyone hear me okay?
Yes,
Okay.
coming through loud and clear.
Okay, great. So I'm going to talk a little bit about using the SIPs in the community, particularly in our clinic here at First Hope. So I'll tell you a little bit about the First Hope program. We were established in 2012, so we've been around for just about 7 years, and we're part of Contra Costa County, California Behavioral Health System. We're funded by the Mental Health Services Act and Medi-Cal, and we're able to work with families who are privately insured, uninsured, and undocumented, which makes us kind of unique for a county service. We work with youth and young adults ages 12 to 25 who are identified as a result of the SIPS assessment as clinical high risk for psychosis. We're very lucky that we have a very rich multidisciplinary team. We have clinicians, psychiatrists, an RN, an education and vocation specialist, occupational therapist, a parent partner, a peer specialist, and most recently a substance use disorder counselor. Our services are offered in English and Spanish, and our first episode in psychosis services, which are funded by SAMHSA's Mental Health Block Grant, actually launched this week. So we're very excited to start to work with people who have already experienced their first episode. And as Barbara said earlier, defining what that period is different for different clinics. And for us, the first episode would need to occur within the last 18 months. So to be eligible for our program, the client has had to scored what we call SIPS positive on the SIPS assessment. Where we get our referrals from, they really can come to us from anyone in the community, including family. People can refer themselves. We get lots of referrals from schools, medical providers, therapists, and clergy. So what will happen is when someone calls us, we do an initial phone screen, which is what Barbara talked about a little bit earlier, and that's completed by our clinician of the day. And our phone screen includes getting information about possible clinical high-risk symptoms, the onset, the frequency, any changes in behavior or functioning, a very brief medical history, and a family history of mental illnesses, particularly psychotic disorders. We also look for the presence of co-occurring disorders, including autism spectrum disorder, and we consider and evaluate those on a case-by-case basis, particularly for the autism spectrum disorders, keeping in mind that the IQ would need to be above 70. And also, as Barbara mentioned earlier, there are other tools that can be used, and we also use the PRIME screen that we will often hand out to other providers in the community, and then they fill it out with the client and send it back to us. So if we determine that a SIPS is indicated after doing the phone screen, the client and their family are invited to come into First Hope for an assessment. So how do we use the SIPS at First Hope?
Yeah.
Ideally it takes about 1.5 to 2 hours. Like Barbara said in the beginning, when you're learning to utilize the SIPS, it does take a little bit to get used to. So usually in the beginning, it will be closer to the 2 hours. Typically 1 to 2 clinicians are present when administering the SIPS. When there are 2 clinicians in the room, one is identified as the lead assessor, and the second is there for observation and acts really as a second set of eyes and ears. After completing the assessment, we have the client and the family leave the clinic, and the clinicians will consult with each other and score the SIPS. First Hope currently has a contract with Dr. Walsh that allows for us to have consultation calls, and we use those calls regularly. If there are questions regarding the presentation of symptoms or the scoring, our staff may consult with Dr. Walsh to obtain clarification and to verify the accuracy of our scores. So once the scores are tallied, the client and the family are brought back to the clinic for an additional appointment in order to deliver the results of the SIPS. And we provide treatment recommendations. So if the person is SIPS positive, we invite them to be part of the First Hope program. And if they are not, then we will provide referrals to other community resources. So some of the benefits of using the SIPS in a clinical setting. The SIPS really provides an opportunity for the clinician to develop rapport and develop a therapeutic relationship with the client and the family right from the beginning. Often the SIPS is the first time that the client is able to relay his or her individual experience. And it can be very profound for that client. Often they have not been asked questions that are on the SIPS, and they're very eager to tell you what has been happening for them. The SIPS also provides a nuanced clinical picture of the strengths and deficits that will assist the clinician and the team in directing the treatment planning and triaging needs. It really helps to identify where to intervene first. For example, often the kids that we see are in school, and school is often the biggest stressor for them. So in deciding where to start first with treatment, often we'll bring in the educational specialist sooner rather than later. And those are needs that are identified in the SIPS. So in addition to identifying clinical high-risk symptoms, the SIPS also illuminates additional areas of concern. So it will ask about suicidal ideation, any self-harming behaviors, any sleep issues, social functioning, and academic and vocational functioning. It really gives a full picture of what's going on and can provide a roadmap for treatment. Although the SIPs may lean on the side of being overly inclusive, it's important to remember that the client is coming into the clinic because things are not going well for them. There's a decline in functioning, or they're experiencing symptoms that are very bothersome, whether those affect their academic, vocational, social, or emotional functioning. The client and the family will benefit from the array of services offered. And like Barbara mentioned earlier, these are young adults and kids who want help. They know that something is wrong, and the client and the family are often ripe for getting assistance and participating in treatment. So there are some challenges of using the SIPs in the clinical setting. Barbara also alluded to this earlier, that using the SIPs as an assessment tool and not necessarily an open-ended clinical interview. It can be difficult to take off your clinician or your therapist hat and not psychoanalyze the client's answers. If you're trained as a therapist, you want to know more, and often because you're curious or you have some ideas about what may be going on with the client and you want to gather more information. But really, during the SIPS assessment, that is not necessarily the time to do that. If the person is SIPS positive, you will have ample time to go into their issues more deeply. Because if you try and do that during the SIPS, it really can distract from the purpose and goal of the SIPS, and it takes much longer to actually complete the SIPS. Deciphering clinical high-risk symptoms versus obsessive compulsive disorder, this is probably one of the most difficult differential diagnoses to make, at least in my experience. It's trying to tease out what is obsessive compulsive disorder. One way to do that is asking the person, what happens if you do not engage in the behavior that helps reduce the stress around the obsessive thoughts. And often the answer will help clarify whether it's clinical high risk or obsessive compulsive disorder. And often those are the cases that we will consult with Barbara about. The other challenge is when there's substance abuse. It can really complicate the presentation of symptoms. And it's really important to find out if the symptoms that the person is experiencing are present in the absence of using the substance. And typically what we'll do is if someone is actively using, we will ask to wait 30 days and see what symptoms are left, what symptoms persist after the person stops using the substance. And, as we all know, asking someone to just not use for 30 days is often very difficult, especially when they are, deep in their addiction. So that presents its own kind of special circumstances and complications. Also, sorting out trauma. A lot of the people that we see come to us with having some type of trauma, whether that's PTSD or complex trauma, and being able to sort out the symptoms that are directly related to the trauma and would be an expected reaction to the trauma versus what is clinical high risk. And Barbara alluded to that earlier, the person who had been experienced a sexual assault is, afraid of others in the community, that, that would be a normal reaction to an abnormal situation. If that person said, anything kind of more elaborate and alluded to there being a deeper paranoia other than the reaction to the trauma, then we would want to find out more and be able to determine whether that was clinical high risk. So another challenge would be utilizing the SIPs in a forensic setting, particularly juvenile hall. We work very closely with the mental health clinicians in juvenile hall, and they will often ask us to come in and administer a SIP to determine whether the person is at clinical high risk for psychosis based on some of the symptoms that they're experiencing. And what really complicates things is that we know when kids are in juvenile hall, the environment is very restrictive, it's very controlled, and it's very stressful. So when someone is under these circumstances, especially when they experience higher levels of stress, that can exacerbate symptoms. One thing that comes up is issues around confidentiality. And when I meet with someone in juvenile hall, I have to tell them that their answers are not necessarily confidential. If they have an active criminal case, the information that they give me and the results of the SIPs may be subpoenaed or may be asked to be presented to the judge to determine what their probation may be or what their sentencing might be. So that in and of itself presents a complication because the client may not be as willing to report everything to you. So developing a rapport with the person in juvenile hall from the beginning, making them at ease is important so that they feel like they can open up and tell you what's going on. There's also situational stressors in juvenile hall that impact symptoms, particularly those related to suspiciousness and persecutory ideas, which is P2 on the SIPs, and also perceptual abnormalities, which is P4 on the SIPs. An example, a young person who has recently arrived at juvenile hall reports feelings of being watched or singled out. Well, of course, because they have eyes on them 24/7, and if they are acting in a bizarre way, they may be singled out. So really trying to figure out what is a result of their environment versus what may have been there before, or is it the stress that they're experiencing in juvenile hall that has exacerbated symptoms that may have been there before. Also, for P4, someone may disclose that they feel more sensitive to lights and sounds. I don't know if anyone has been in juvenile hall, but there's usually not a lot of natural light, and the lights are pretty harsh, and there's lots of different sounds. I had one kid describe to me that he would hear whispering, and in digging a little bit further, his room had a vent in it that was connected to other rooms in juvenile hall, and he was truly hearing whispering. So if you took it on face value, you may think that that was a clinical high-risk symptom, but taking into account where the person is really changes the perception and what you make of what their symptoms are. So again, it can be difficult to determine what is related to the environmental stressors and what is possible clinical high risk. One other challenge is if there's a recent addition of medications, particularly antipsychotics. So if someone is symptomatic and they start medication 30 days before you see them, you really want to do, in a sense, a retroactive SIPs and to find out what was going on for them and what were things like approximately 1 month before they started the medication. And that can be challenging for a young person to really kind of, draw that line between what was happening a month before the medication and how things have changed since. So in doing this SIPS for 6.5 years, I've learned some lessons over the years. And the first one is to seek consultation and to ask questions. It's okay not to know the answer to everything. And, even after having done them for this long, I will still pull a colleague into my office and just run some things by them because I'm not sure. And even to this day, I will ask Barbara questions, especially around the OCD stuff because that does really get very complicated. Make yourself familiar with DSM-5 diagnoses in order to assist with the differential diagnosis. It really will make life much easier and will allow you to kind of tease out as you're going along what's what. And so the more familiar you are with the different criteria of other diagnoses, that will make things much easier and much more efficient. There is a learning curve with doing the SIPS, and it's really important to be patient with yourself. And to know that it takes practice to understand and master the nuances of the SIPs. When in the beginning, when we were first starting the First Hope program, we practiced SIPs on each other, and really just to get used to the language and to get used to the questions, so that when you're in the room with a client, you're not kind of stumbling over the words and how the questions are asked. So colleagues have reported that it takes at least 1 year minimum, really, to feel comfortable administering the SIPs and feel that you have sort of mastered how the questions are asked and what the follow-up questions are. It really, it may sound odd to say enjoy the process of administering the SIPs, but, my experience with doing the SIPs, it really is a unique situation, and you're providing a valuable service to the clients and their families just by means of administering the SIPs. You'll see a kid come in and they are very anxious in the beginning, and you see how they relax over the course of, the hour and a half that you're with them. And it really can be very therapeutic for them just to be able to talk about things that they have not been able to talk about before. And, especially with the younger kids, when I was told that we would be doing SIPs on 12-year-olds, and it's, a 45-page assessment, I could not, wrap my mind around how that was going to happen. And, my experience has been that even with the younger clients, talking with them really kind of opens up this floodgate for them. And, we'll offer breaks and, bathroom breaks, or if they want to have a snack. And more often than not, they don't want to. The kids and the young adults don't want to stop talking. And they really feel very validated just by the administration of the actual assessment. So it's pretty incredible to be part of and to watch that unfold. So I guess now we will turn it over to Kate and answer some questions.
Thank you, Jennifer, and thanks again to you both for putting together that beautiful presentation and covering so much rich material in so little time. I realize that when we're talking about the SIPs and doing these trainings, they are multiple days. So that was a fantastic overview. Thanks to you both. We have a lot of questions, and what have we got, like 25 minutes, and I saw Barbara furiously typing away and answering some of the questions in the public chat as well. So just in case people weren't following that, that's a good place to go back and check to see if you got your questions answered. But we certainly were pulling out a few also, and Tamara, feel free to jump in with questions as well if I'm missing any. But just heading back up some of the chat, and some of the questions that came out of Barbara's talk. Barbara, you did a lovely job of talking about this component of the SIPs and the assessment where if something's not better explained by another diagnosis. And I know you spoke to that a little bit, but then there was a question, and I'm trying to, here we go. So someone has done several SIPs on young folks who have had no treatment history and are now just experiencing symptoms that could be related to another disorder, but it's too early to diagnose. At what point do we say they're better accounted for when it's so early on and the symptoms just began? And also putting that in line with the fact that many of the youth that meet criteria for depression or anxiety at the time of the intervention, how do we sort of differentiate that between CHR or better accounted by? And it's a question that I often have as well, so I'm excited to hear this.
Okay. And first of all, anybody who typed a question, if I didn't get to yours, I do apologize. I was trying to get to as many as I could, but anybody can email me, please. I'm more than happy to answer questions. So what I say to people is you want to apply your professional ethics to the answer to this question. There are some times where it is indeed too early to determine, is this concurrently existing with another anxiety disorder, or Jennifer mentioned OCD. I've done over 2,100 SIPs in my career. Sometimes that still knocks me to the wall, that differential, okay? So this is what I would say to you. Ask yourself, if you are not sure if it's coexisting or better accounting for, ask yourself, will I do any harm? If you accept that person into your treatment program, will you be doing them any harm? Or will you be keeping them from another specialty program that might be able to help them better? So, for example, when I struggle with that differential for OCD, sometimes I will make the decision to send them to the OCD clinic here at Yale, and then 2 months later they send them back to me because it isn't OCD. But I always try to do it based on, am I in any way going to harm this person? Am I in any way going to keep them from a treatment that is better or more appropriate for them? Someone who I didn't get a chance yet to answer their question asked about comorbid substance abuse. And, you know, with other substances, you really go by the DSM criteria. Are they 30 days clean of the substance? Do the symptoms still exist? Then you no longer better account for it by substance. But with marijuana, that can be very, very difficult. So again, I go through the same thing. Should I better send them to a substance abuse program rather than take them into our clinic where our primary focus will be their CHR symptoms? We will also address their substance use, but it wouldn't be our primary. So again, if you're not going to do them harm or keep them from a better treatment, you certainly can accept them in. I call it the possibly category. Sometimes it's very clear it's better accounted for. Sometimes it's very clear it's not. But then you get those gray areas where it could possibly be better accounted for, but it isn't definitively. And then I say, use your ethics.
Thanks, Barbara. And then another question here, and this could be for either you or Jennifer, is you spoke about the PQB, and there were some questions around the cutoff scores for the PQB and at what stage to indicate assessment on the SIPs. Do you have any further information on that?
We no longer use the PQB here. We used to. We don't anymore. But I know when I travel around the country, many, many people use the PQB, and I believe they go by the 20 cutoff point. a total score 20.
Great, thank you. And can you speak more about why you're not using the PQB? Or are you using something instead?
We do use something instead now. What we found is if we use the PQB as a self-report, they did it themselves, we were getting just too many people that hit positive on the PQB. So it was really, it was a matter of resources, Kate. We just were doing so many steps that, you know, we had to try and narrow it down better. So we came up with our own screening form that we use now instead.
Gotcha, thank you.
Can you share that?
Oh, sure. Absolutely.
That would be great. We'll be able to put that on the learning community along with some other resources that people were asking for. So that would be great if we can connect around that after the webinar.
Sure.
There was another question here about distinguishing depressive symptoms from negative symptoms. Could you speak to that?
Yeah, and that is, it's very involved. It does take practice, as Jen said. You know, you get used to the differences in some of, you know, so for example, lack of motivation certainly can be a negative symptom of schizophrenia. It can also be a symptom of depression. So you look for that slide that said, you know, the individual impact. I think that's really important. A lot of times when I'm using the videos for training, there's a video of a young girl who failed the college course, and people always rate her high on avolition because they assume that she didn't do well in school because she wasn't motivated, when in fact she was extremely motivated, but she was unable to perform in college because her lack of focus and attention made her fail the course. So you really have to listen to the person's internal interpretation of the symptom, and that can direct you to, is this the negative side of psychosis, or is this truly linked to their mood? You know, if you hear it only occurring during a mood episode, never outside the mood episode, you can feel more confident that it is better accounted for by their depressive disorder.
Thank you.
Whereas, and you know, the negative symptoms exist regardless of their mood episode.
And then you touched on this a little bit in the chat box, but I know people have had questions about it, which is this differentiation between autism spectrum and CHR. And you made a recommendation of somebody who's written some publications, Jennifer Foss.
Yes, absolutely. Jennifer Fossbag used to be at the Yale Child Study here at Yale University. They specialize in autism, and she and I worked very closely over the years because of the similarity in the presentation of some of the autism symptoms and the CHR symptoms. And she wrote some very, very, I think, very well-authored papers on the differential, and I would refer people to her articles. She's no longer here at Yale. She's down at Mount Sinai now, but excellent work on it. But one of the major distinctions is what I talked about in terms of the prodrome being fluid or movement. You know, there's movement going on, whereas very often in autism spectrum, it starts at a very young age and is very long-standing. So that's one of the initial differentials that you look for. Having said that, I want to be clear with people. I have assessed young people who did meet back in the day when we had Asperger's. They met for Asperger's and also turned out to be CHR, but clearly there was the onset of new and different symptoms that took place when they hit puberty, on top of what had been their pretty long-standing autistic symptoms.
Brilliant, thank you. And I suspect that we'll be reaching out to Jennifer for a webinar specifically on this topic, because I know it's something that we keep coming back to, so thank you for that recommendation.
Oh, you're very welcome.
Question for both you and Jennifer, which we've been seeing a number of times on these webinars and in conversation just generally about the use of the SIPs for research versus as a clinical tool to determine eligibility for a service. And I know, Jennifer, you were really speaking to that in your presentation, but I just wondered if you guys have got any specific comments for individuals who raise that concern that this is, as the SIPs, it's really a research tool and we shouldn't and can't be using it in a community setting. How do you guys respond to that?
I think you can use it in both settings. It was initially authored as a research assessment, but it is being used all around the world in clinical settings as well. The only thing I would say to that, and I think Jen addressed this, it does take an hour to an hour and a half. And in a clinical setting, you don't always have that time. Exactly why the mini SIPs is coming out now. That is it already is authored, but the reliability and all of that is being done on it right now. But it was specifically authored for clinical settings.
I got to admit, I gave a little cheer when I saw that. I was quite excited. I'm very excited about it too, Kate. Yeah, I kind of geeked out on that one. Jennifer, any thoughts on that or any additional comments?
Yeah, I mean, I agree with Barbara in that the time it takes can be, long and can feel kind of tedious when you have someone who's answering yes to every question. But I think, if you can get through it, I think the information that is generated is so important and really, like I said earlier, can help direct what the treatment will look like. And for us, if we're not going to work with that person for, if they're SIPS negative, it really helps us steer the person and their family in the right direction as to what treatment may be helpful, based on what comes out of the SIPs.
Right.
The other thing, Kate, is in terms of the time element, in clinical settings, if they don't have the time to do the entire SIPs, they can break it up, and as long as they do the 5 P symptoms in the same sitting, that is valid.
And as an extension from that and using the SIPs for a clinical intervention and targeting the clinical intervention, as you said, Jennifer, how often are you recommending that people do the SOPs, and how are you using that then to target interventions?
I think sure. So very important thing that I didn't mention, and I should have, the SIPs is only used at baseline or if you haven't seen the patient for 12 consecutive months. If you are seeing the patient in a treatment program or on a regular basis, you can use it as frequently as once a week, but you only use the SOPs portion. And the way that you use the SOPs is the rating based on section. You will have exactly what your previous rating was based on. You will ground the person. The last time I saw you, you told me that you heard a voice twice a week, blah, blah, blah. So you ground them in exactly what they reported to you when you saw them last, and then you follow up, how is that today? Has it changed in any way? Is it better? Is it worse? Happening more frequently, more distressing to you? And then at the end, after you've gone through everything they reported, has anything new in this area, whether it's unusual thought contents or suspiciousness or perceptual abnormalities, has anything new like that developed since I last saw you? Again, remembering the prodrome is fluid and unraveling. Just because they didn't have a perceptual abnormality when you saw them last time doesn't mean they don't have one now. Again, remembering that as their stress level goes up, their symptoms are going to go up. I always share my most embarrassing story, but when I started working at Prime over 21 years ago, it was in January of that year. And around July, I was feeling really good about myself. I was like, hey, Barbara, you're a great therapist. All your patients are better. Yeah, it had nothing to do with Barbara and everything to do with the fact that it was July and they weren't in school. And so all their symptoms remitted. And you will see that clearly. It forced us to redefine remission, because you are going to get improvement and decline based on their stress levels. But the overall trajectory should be upward. So in other words, the decline should never go lower than where they were when you first saw them. If you see improvement and decline with a downward trajectory, you immediately know it's time for medication intervention at that point.
Brilliant. Thank you for that. It's really, really nice clarification and for sharing that story. It really resonated with some of the team discussions I remember having as well. Jennifer, could you speak to the training piece? Because I know there have also been concerns about taking to community clinicians and training them in this quite subtle and nuanced assessment. And Barbara, you spoke to some of the kind of training prerequisites, if you like, of familiarity and knowledge about psychosis and attenuated psychosis. But from your perspective, Jennifer, what have you noticed in terms of training team members who are doing this in the community?
Yeah, us here at First Hope, we've been very lucky to have Barbara come and train all of our staff. And being here from the beginning, I've seen multiple trainings with Barbara that are sometimes, 2 to 3 days, and I still go to them. It's sort of a joke between Barbara and I that she sees me there every time, but, you can't be trained enough, I think. And, practicing what you learn, I think, is so important also.
It always amazes me. I don't know how she isn't bored silly watching me again, because I think at this point she could do the training herself. But I do think she adds something to the trainings at First Hope because she has real-world experience, and I think other people attending can really relate to that.
That's brilliant. Thank you.
Yeah, and when doing the SIPs, I think that's when having a second who is really there just to observe, I think they are able to really learn and see different kind of just personal styles of doing the SIPs, but allowing for people who are new to shadow the more kind of seasoned SIPs assessors is helpful.
Yeah. There's a question here. Oh, sorry, go on.
I was just going to say, I just happened to notice Tamara's question about using the SIPs for targeting clinical treatment intervention, and I don't think I really addressed that, but as one of the SAMHSA sites, we do have defined step care. So, we do our initial SIPs at entry, and everybody starts out with brief supportive psychoeducation. It's a manualized form of treatment for CHR. And then at the 2-month point, they're reassessed on the SOPs and with the risk calculator. And based on the outcome of those, there are 3 different areas, 3 different legs of treatment, so to speak, depending on their scores, where they can move in. Whether it's going to be CBT, a form of CBTP, or whether it's going to be more brief supportive psychoed, or if it's really severe and they need to go to medication management. It also will define what other supportive treatment they need, so who needs an education-supported specialist, an employment, maybe help from a peer support specialist, who needs a social cognition group. So again, I think it goes back to that slide of taking into account the individual's total personal problems, looking at the whole big picture, including sleep disturbance, which is so crucial because when CHR patients aren't getting slow wave sleep, we see major exacerbation in their sleep, in their symptoms. So we always want to make sure that's on the forefront in treatment.
All right, thank you. So we've just got a couple of minutes left. There's just 2 questions I really want to make sure we get out, or maybe 3. One here about clarifying the clean time needed prior to the administration of the SIPs, especially where THC is concerned. Is there a quick answer to that?
I mean, I certainly would not conduct a SIPS on anybody who is high or had been high, just gotten high that day. You know, we really try to have, if possible, at least 48 hours of their being sober. Again, just to conduct the interview. That's not the same criteria that defines if it's a substance-induced symptom. That you go by the DSM criteria. But just in terms of conducting the interview, I would never do it on anybody who was just recently high.
Another quick question. Do you find that kids get referential when being asked these questions for the first time, since the questions you're asking implies you know what's going on with them?
Not at all. I got to be honest with you, Kate. My experience is, as I said, it's really important how you introduce the assessment. When you tell them there's no right or wrong answers and you ask everybody the same questions, typically what the kids will do is stop me halfway through the assessment with shock in their eyes and say, do you mean to tell me there's enough people that have these symptoms that you wrote them down? And I say, yes, this is what I do all day, every day. And that really is normalizing to them, and it opens the door for your CBT intervention. It really does.
Yeah, I completely agree. And this one might be too big for the 2 minutes that we've got remaining. But where did it go? Here we are. How can you speak to childhood trauma? We are getting many referrals, especially of teens that have experienced severe early childhood trauma where the symptoms started after the trauma, generally auditory or visual hallucinations, but have increased as they've got older. Big question.
Oh boy, that's a tough one to answer in 2 minutes.
I know, I'm sorry. I want to throw it out there as recognizing the importance of understanding the childhood trauma in the context of the SIPs and having closely assessed that.
Yeah, Jen, you want to field that? I know you guys see a lot of trauma cases.
Yeah, I mean, if you look at trauma in and of itself as a risk factor, and, you know, we may not necessarily be assessing what happened to, you know, someone who's 20 when they were 2, but to see sort of how that comes out and is affecting their daily functioning today. So I think that's one thing, you know, because you're right, so many of the kids that we see have had significant trauma. And with the SIPs, you know, you're really looking for things that have started or worsened in the last year. So if a kid has always had symptoms related to their past trauma and all of a sudden things are changing in the last year, that's what you want to pay attention to.
Brilliant. Thank you. So I just want to say thank you to you both for joining and for the participants who've stayed on through the questions. That's been fantastic, and for being so active with all of these wonderful questions we've had. Please take the evaluation survey. That is the links there in the public chat. I'm going to echo Jen and say I just love using the SIPs as well. I find it such a rich interaction with the clients, learning so much. Haven't had anyone react negatively to the questions. It has been much more like you described, Barbara, very, very normalizing. So I think it's been a fantastic experience. and we will continue this conversation on the learning community, and we'll be placing some of the resources on there as well. So thank you, everybody, and look forward to seeing you next month where we will be talking about family interventions. Thank you. Oh, and join the learning community to continue the conversation, says Tamara. Yay, let's do that. All right, thanks a lot. Bye-bye.
Thank you so much, Kate. Bye-bye. Thank you.